Today, my teammate and I are going to give a presentation on tumor markers. So let's start with the introduction. So what are tumor markers? Tumor markers are molecules which is present in or produced by cancer cells or any other cells in response to cancers or any non-malignant conditions. This can be detected in blood, urine, stool and other bodily fluids. Tumor markers are also called tumor index substances. Tumor marker not all cancers produces tumor markers, and not all markers are cancer specific. Tumor markers are mainly uh, proteins. Um, Now let's discuss about the purpose of the tumor markers. Tumor markers are used for follow-up of cancers and to monitor the effectiveness of the therapy. It also detects the reoccurrence of the cancer. Let's discuss this graph. This graph is the monitoring of the serum level of beta HCG in chorionic carcinoma. As you can see, the graph goes down when the treatment starts and disease reoccurs after the graph goes up after the disease reoccurs. Uh, Tumor markers also facilitate the detection of the cancer. But however, not uh, however, tumor markers are not always released in cancers, and non-malignant conditions can also produce tumor markers in non-cancerous condition. So, to confirm a cancer, the physicians must verify with other tests like biopsies and imaging. Tumor markers can serum level of tumor marker may indicate roughly the tumor load, which in turn can help us to detect whether it can be curable or not. Now let's discuss the mechanism of the tumor marker. Tumor marker alter the gene expression, which results in production of abnormal proteins. And now let's discuss about oncofetal antigen. What are oncofetal antigen? In fetal conditions, some genes are produce proteins which during differentiation is repressed and do not produce in adult cells. But due to malignant conditions, it can de-repress and it can again produce in adult cells. These antigens can be used as tumor markers. Examples are alpha-fetoprotein in hepatoma and carcinoembryonic antigen in colorectal cancers. Now, the ideal characteristics of tumor marker. Tumor marker have to be highly specificity, like it should be unique to only one type of tumor. It also should have high sensitivity so that it can be detected in small tumors also. Plasma level of tumor should tell us the amount of cancer present in the body. It should be cost effective, easy and reproducible test. Tumor marker should not be present in healthy tissues. Now let us discuss the classification of the tumor markers. It can be oncofetal antigens like AFP and CA. It can be hormones like HCG, antigens like PSA, glycoproteins like CA125, and receptors like estrogen receptors and progesterone receptors, which are going to discussed by my fellow teammate. Now I am going to hand over the mic to Ranjini.
So, common tumor markers type 1 are as follows: alpha fetoprotein for liver cancer and germ cell tumors, and carcinoembryonic antigen for colorectal, pancreatic, and breast cancer, and human chorionic gonadotropin for testicular tumors and choriocarcinoma. Common tumor markers type 2 are as follows: so, PSA, prostate specific antigen for prostate cancer, and CA-125 for ovarian cancer, CA-19.9 for pancreatic and gastrointestinal cancers, and CA-15.3 for breast cancers. Alpha fetoprotein, it is increased in the circulation of patients with hepatocellular carcinoma and in pregnancy with fetal malformation in neural tube. It serves as a function of albumin in fetus. This is called fetal albumin. And AFP level above 300 nanogram per liter is often associated with cancer, but it may be non-malignant liver disease. But AFP level above 100 nanogram per liter is confirmed as cancer. Carcinomembryonic antigen, its level is markedly increased in colorectal cancers. Over 50% of persons with breast, colon, lung, gastric, ovarian cancer, and pancreatic and uterine cancer have elevated levels of carcinomembryonic antigen. And heavy smokers and about 5% of healthy persons have elevated plasma levels of carcinomembryonic antigen.
Beta HCG. The beta HCG is synthesized by the syncytotrophoblast, which are the cells of placental villi. The HCG is a glycoprotein and has two subunits, alpha and beta. The alpha subunit is similar to that of FSH, LH, and TSH, whereas the beta subunit is specific for HCG. Beta HCG is generally increased in case of choriocarcinoma, hydatidiform mole, and germ cell tumors. About 60% of testicular cancers secrete beta HCG. A value greater than that of 1 lakh international unit per level denotes is a sign of trophoblastic tumor. Prostate specific antigen. Prostate specific antigen is produced by the secretory epithelium of the prostate gland and normally secreted into the seminal fluid. In seminal fluid, it helps in the liquefaction of the seminal coagulum. PSA is a protease, and in serum it is seen complexed with alpha-1 antitrypsin. The prostate specific antigen is especially the complexed one is increased in case of prostate cancers. PSA has been found to be elevated in 60 to 70% patients with prostate cancer. The normal level of PSA is 4 nanogram per milliliter in serum. Most of the PSA is complexed with alpha-1, complexed with anti-chymotrypsin. The free PSA can be measured separately. The index between the ratio between the two is a better index for carcinoma prostate. The free PSA is inversely proportional to the probability of occurrence of prostate cancer. Estrogen receptor. Estrogen receptor is a protein which is found in the nucleus of breast and uterine tissue. The concentration of estrogen receptor denotes whether a person with breast cancer will respond to the therapy with tamoxifen, which is a estrogen which binds with estrogen and blocks the action of estrogen. A patient with who is ER negative has a more chance of reoccurrence than a person who is ER positive. Now I will hand over the mic to my fellow teammate.
Progesterone receptor. Progesterone receptor is located in the nuclei of both breast and uterine tissue. Progesterone receptor is the same prognostic value as the estrogen receptor. Tissue that doesn't express the PR receptor is less likely to bind estrogen analogs used to treat the tumor. Person who tests negative for both estrogen and progesterone receptor have less than a 5% chance of responding to endocrine therapy. Those who test positive for both estrogen and progesterone marker have more than a 60% chance of tumor shrinkage when treated with hormone therapy. Cancer antigen 125. Cancer antigen 125 is a tumor marker for ovarian cancer. The name is so given because it reacted with a monoclonal antibody, originally termed as OC125. Approximately 75% of persons with ovarian cancer will have elevated serum levels. The CA125 levels correlate with tumor mass. Clinical applications. Screening, that is PSA for prostate cancer, diagnostic aid, but it not confirms. Prognostic indicator, if the serum level is high, then the prognosis is poor. Monitoring treatment response, detecting recurrence, post-surgery or chemotherapy. Example, PSA in prostate cancer. If the serum level of PSA is more than 4 Ng per ml, then it is considered as abnormal value. Increase in BPH, prostatitis and prostate cancer. PSA velocity and free or total PSA ratio improves specificity, used for monitoring recurrence after treatment.
So now coming to the limitations of tumor markers, that is the lack of specificity. Sometimes the tumor markers may be elevated in non-cancerous conditions also, like infection or inflammation, or sometimes like benign conditions, and lack of sensitivity. Some tumors may do not secrete markers also, and there are some tumor markers that are detected in early cancer conditions, like CA125 is not detected in early ovarian cancers, and that's why there are sometimes false positive and negative results. And one of the drawbacks of tumor markers, it cannot replace biopsy or imaging, because this is not one and only test for diagnosing cancer, so that it should not be used alone for diagnosis. And now, how should we interpret tumor marker results? We should always compare with the previous values, and should be always used in conjunction with imaging and clinical symptoms. And we should also consider physiological and non-cancerous causes, because it, as I said earlier, it is not always doesn't. Tumor markers may be elevated in non-cancerous conditions, so we should always confirm it with histopathology where needed. And in the future of tumor markers, we can say it can be used as in future maybe multi-marker panels for higher accuracy, or we can use liquid biopsy for circulating tumor DNA, and genomic profiling for targeted therapy, and AI-based integration for cancer prediction. And maybe in future we can use it as immunotherapy monitoring in PDL1. PDL1 is programmed death ligand 1. So the summary: tumor markers are supportive tools in oncology and used in diagnosis, prognosis, treatment and follow-up. It is not perfect because it must be interpreted carefully. In future, maybe we can use it as a personalized, non-invasive diagnostics. Thank you. Thank you.
Very nice presentation. All of you have participated very well. Sir.
Yes, you have covered almost most of the aspects of the tumor markers. In the previous day, you have presented cardiac markers. Today, you have presented tumor markers. In case cardiac markers, it is highly specific and sensitive. It helps in the diagnosis. You can diagnose acute myocardial infarction from cardiac markers. Even you cannot diagnose by ECG. ECG can fail to prove the diagnosis, but cardiac markers does not fail. But in case of tumor marker, it is not very specific as well as not very sensitive. So it helps in the diagnosis, but it cannot confirm the diagnosis. For confirmation, you must have to do histopathological study or imaging studies.
Biopsy.
But still it is important. Why it is important? For us, it is important for the effectiveness of therapy, as you have said. That is monitoring of the treatment. It helps in monitoring of the treatment. You have started treatment, and after treatment you will see that whether treatment is effective or not. That is before medication, after medication, before surgery, after surgery, before radiotherapy, after radiotherapy. You compare these two values and judge whether your patient is cured or not. If it is cured, tumor markers value will be less, and if it is not effective, it will not reduce. So, again, you have also mentioned very important point, that is, it helps in the recurrence of the tumor. That it lowers, tumor marker has been lowered by treatment, but after a period of certain days or years, it is again elevated. What does it indicate? It remits, it lowers, and again after a few days or years, it is elevated. It indicates recurrence. It indicates the recurrence of the tumor. In this, so it is helpful for monitoring of the therapy, not for exact diagnosis.
Exactly.
Remember.
Hello everyone. Today we are going to present enzyme inhibition. What is enzyme inhibition? Inhibitors refers to the decrease in enzyme activity due to binding of a molecule, and that is inhibition. What are the sites? It could be in the active site or it could be in the allosteric site. What are the types? There are broadly two main types, reversible and irreversible. What is reversible inhibition? In reversible inhibition, basically the inhibitor reversibly binds with the enzyme through non-covalent bonds. It could be an ionic bond or it could be hydrogen bond, and the effect itself is temporary in nature. What are the types? Basically, there are three main types: competitive, non-competitive, and uncompetitive. What is competitive inhibition? In competitive inhibition, the inhibitor is a structural analog of the substrate, and inhibitor competes with the substrate for the active site, and it's a structural analog, so the 3D structure itself is similar. And the effect of kinetics, the Km here is increases and the Vmax is unchanged, mainly because the substrate concentration is increased. More substrate concentration is needed for reaching half the maximum velocity of the enzyme, but the Vmax is unchanged because with enough substrate concentration, the substrate would outcompete the effect of the inhibitor. What are the clinical relevance? Sulfonamides. Sulfonamides are antibacterial agents, and as we know, the bacteria, they have to synthesize folic acids. They cannot absorb it from the nature, mainly because their cell wall is actually impermeable to folic acid. So they combine para-aminobenzoic acid with terryl glutamic acid and form folic acid. But the sulfonamides, they are structural analogs of para-aminobenzoic acid, and that's why they interrupt this process, which leads to bacterial cell death. But the human cells are actually unaffected by this, mainly because we consume folic acid through diet. Methotrexate. Methotrexate is a structural analog of the folic acid, and it competitively inhibits the folic reductase enzyme, which disrupts the DNA synthesis and cell division, so we can use them as anti-cancer drugs. Then we have dicumarols. Dicumarols are structurally similar to vitamin K, so we can use them as anticoagulants. Isonicotinic acid hydrozide, or in short INH, they are anti-tuberculosis drugs and structurally very similar to pyridoxal, but in prolonged use pyridoxal will decrease, which will lead to peripheral neuropathy. Non-competitive inhibition. In non-competitive inhibition, the inhibitor binds to allosteric side of the enzyme and not the active side, and structurally changes the enzyme molecules, alters the enzyme alters the enzyme structure itself, which leads to decrease in Vmax, but the Km is actually unchanged, and we cannot overcome this by increasing the substrate concentration because the inhibitors are not structurally similar to the substrates. Clinical relevance. Cyanides. Cyanides inhibit cytochrome C oxidase in the ETC. The fluorides inhibit enolase and we used it in plasma glucose estimation of blood, because they by inhibiting enolase, it inhibits the glycolysis process, so the blood glucose level is constant. Otherwise, it would have decreased around 5 to 10 mg per dl per hour. BAL, or the British anti-leucide, which chelates the heavy metals. Basically, it has multiple thiol groups in it, which decreases the poisonous effects of the heavy metals like lead or mercury, which restores the enzymatic activity. Now I will pass on the mic to Ria Sultana.
Now I move into the slide uncompetitive inhibition. Here the uncompetitive means there is no competition between the substrate and the inhibitors. The inhibitors bind with the enzyme and inactive the enzyme, and the Km is decreased and Vmax is also decreased. Not reversible by adding the more substrate. And the example is phenylalanine inhibit placental alkaline phosphate. Now, let's see the irreversible inhibition. Here, the inhibitors bind with the enzyme with covalent bond and permanently inactive the enzyme. And here we also, if we can increase the concentration of substrate, the process cannot be reversed. These inhibitors modify key amino acid residues needed for enzymatic activity. The types of irreversible inhibition, there are 3 types: group specific inhibition, reactive substrate analog or affinity levels, suicide inhibition, or mechanism based inhibition. The group specific inhibition, here the inhibitors react with the enzyme which has side chain of amino acid residues. There are example, acetyl cholinesterase inhibits by diisopropyl propyl phosphofluoride, and the heavy metals like Ag2+, Pp2+ forms bond with cysteine residues of enzyme. Now I hand over my mic.
Reactive substrate analog or affinity level. Here, the inhibitor is a structural analog of the substrate, like in competitive inhibition. But unlike competitive inhibition, it forms covalent bond with the enzyme. It also differs from suicide inhibition in that suicide inhibition, the inhibitor in suicide inhibition, the enzyme in suicide inhibition has an active role in the enzyme in suicide inhibition has an active role in its own inactivation. The inhibitor in this case are specific for enzyme active sites. Example include 3-bromoacetol phosphate, or BAP for short, which inhibits the enzyme phosphotriose isomerase. Suicide inhibition, also known as mechanism-based inhibition. It's a special type of irreversible inhibition. The inhibitor here is also a structural analog of the substrate. Hence, the enzyme mistakes the inhibitor for the substrate and binds with it. But during reaction, the enzyme inactivates the inhibitor, and this results in the covalent bonding of the inhibitor and the enzyme. The enzyme here has an active role in its own inactivation, and hence the term suicide is used. Example include the use of allopurinol in the treatment of gout. Xanthine oxidase turns allopurinol into oxypurinol, which then covalently binds with the enzyme and inhibits the enzyme. Another example include the anti-inflammatory drug aspirin. The enzyme cyclooxygenase, or COX for short, turns aspirin binds with the serine residue of COX, and this prevents the synthesis of prostaglandins. Allosteric inhibition is a type of enzyme regulation The inhibitor in this case are not a structural analog of the substrate. Inhibitors in this case are known as negative modulators, which are of two types, homotrophic or heterotrophic, in which case the homotrophic inhibitors are the substrate itself. The inhibitors here binds with the allosteric site of the enzyme and induces a structural difference in the enzyme, which either reduces the affinity or the efficiency of the enzyme. Uh, Inhibitors here forms non-covalent bonds with the enzymes and hence are usually reversible. But some may form very tight non-covalent bonds and this may produce a long-lasting effect. For the kinetics, allosteric inhibition does not follow Michaelis-Menten law for the kinetics. It does not form hyperbolic curve but rather forms a S-shaped sigmoid curve. This is due to the presence of multiple active sites in the enzyme and cooperative binding. Examples, some of the important examples of allosteric inhibition include: number 1, the inhibition of phosphofructokinase by ATP or citrate in the rate limiting step of glycolysis. Number 2, the inhibition of aspartate transcarbamylase by the end product CTP in pyrimidine synthesis pathway. Number 3, the inhibition of citrate synthase by ATP in TCA cycle. Types of allosteric inhibition. Based on whether the inhibitor decreases the affinity or the efficiency of the enzyme, it may be divided into two types, K-type and V-type. The kinetics of K-type are similar to competitive inhibition and the kinetics of V-type are similar to non-competitive inhibition. An example of K-type inhibition is the inhibition of phosphofructokinase by ATP and citrate. An example of V-type inhibition is the inhibition of fructose 1,6-bisphosphatase by fructose 2,6-bisphosphate. Now I'll pass to Mike.
So now we come to the last topic of the day, that is feedback inhibition. So in this case, the end product of a pathway inhibits an earlier enzyme. It's usually allosteric and it prohibits the unnecessary accumulation of products and it prohibits the
মাইকটাকে সামনে নিয়ে বলতে হবে
it prohibits the unnecessary accumulation of products and conserves energy. Now we look at some of the examples. We can say glucose 6-phosphate, which inhibits the action of hexokinase. The CTP inhibits the actions of aspartate transcarbamylase, and heme, which inhibits the action of allosynthase in heme biosynthesis. Now if we see at the flowchart here, we can say the succinyl CoA and glycine, which with the help of allosynthase, it becomes delta aminolevulinic acid. In short, we can say ALA. And with the help of aldehyde and succinyl acetone, it becomes porphobilinogen, and which later becomes photoporphyrin 9 and ultimately becomes heme, which inhibits the action of allosynthase. So that's all. Thanks for listening.
First of all, you should be audible. So just while speaking, be careful that your voice can reach the listeners. Otherwise, presentation was good, nice presentation, and your preparation is also good, I feel. You have given a lot of examples.
You have missed one plot, that is Lineweaver bar plot for description of the inhibition. Enzyme inhibition can be better studied by the Lineweaver bar plot or double reciprocal plot than Michael's plot. So you should also mention when describing about the enzyme inhibition, the plot that is known as double reciprocal plot or Lineweaver bar plot. X-axis or Y-axis. X-axis is 1 by V, actually 1 by X. Substrate 1 by S, and actually 1 by V. X-axis, this is a very important plot. You should mention it. Examples should be much more examples in competitive inhibition. Competitive inhibition is very much useful in clinically to design a drug for treatment. Most of the examples we have sorted out, but one thing, you have cholesterol lowering drugs. You have not mentioned cholesterol lowering drugs.
Statin.
Statin.
Hey, এটা ব্যাটারি কমে গেছে. One thing is statin you have not mentioned, and what sir said, like, see, you go to the graph, I'll show you. Go to the graph. Bring it back up. So this is the kinetics, right? So what sort of kinetics is this? It could be zero order, it could be first order, it could be second order, right? It could be zero, first or second order. Now in these like hyperbolic curves, it is very difficult to find out the actual values because point to point it is curved, it is not straight. So we cannot extrapolate whatever values we get during the experiment. That is why these graphs have been replaced by straight line graphs. One of them is Lineweaver bar plot. Another is AD Hofstee plot. There are few plots which are used because of their linearity. That it cuts like normal graph in x and y axis. Right? That is why it is innovation of these graphs actually made this thing possible to understand the kinetics. Because these graphs are very difficult to understand. You cannot plot.
The two parameters, one is a Km value, another is the Vmax. These values are altered, not by either Vmax or Km value, or both. Okay? But this actual value of the Vmax and Km value cannot be measured accurately by this graph. These two parameters can be accurately measured by the Lineweaver bar plot because it is linear, as Dr. Sandeep Sir mentioned. It is not linear, it is curved, hyperbolic. Okay? So you should mention that double reciprocal plot also, along with this curve.
Good afternoon, respected teachers and all my dear friends. Today I, Romi Ghosh, and my teammates. Today I, Romi Ghosh, and all my teammates, Rosie, Samya, and Rohan, will be presenting in PowerPoint presentation on the topic Aromatic Amino Acid Disorder. We all know what are amino acids. Amino acids are the compounds which combine together to form a protein. So what is an aromatic amino acid? Aromatic amino acids are the amino acids which has the presence of an aromatic ring. These aromatic rings are generally the benzene ring. The common types of aromatic amino acids are tyrosine, tryptophan, phenylketonuria, and Alkaptonuria.
Alkaptonuria টা কোনো অ্যামিনো অ্যাসিড না, ওটা একটা অসুখ, রোগ।
Sir, it comes under aromatic amino acid disorder.
মাইকটা সামনে আন।
Tryptophan all are aromatic amino acids because the last three you have mentioned Alkaptonuria. It is a disease.
Okay,
Not
sir.
amino acid.
Alkaptonuria is not an amino acid.
Sir, it comes under disorder
Yeah,
of
you have
aromatic
only
amino acid disorder.
You have only one amino acid, aromatic amino acid. What is that? Phenylketonuria, tyrosine, tryptophan.
Yes, sir. Tyrosine, tryptophan.
Now,
So,
Basic amino acid.
phenylketonuria. So,
Which is the
phenylalanine.
basic, which is the basic as well as aromatic amino acid.
So, here is just
Basic as
phenylalanine.
well as aromatic. The histidine.
Histidine.
Regarding histidine, there are also disorders. So, phenylalanine, tyrosine, tryptophan, and along with this, there will be histidine. Not alkaptonuria. It is not amino acid.
Hey, go ahead.
Go ahead. Yes. You may make correct mistake.
Aromatic amino acid disorder. Aromatic amino acid disorder are very rare, inherited, autosomal recessive in nature. So, aromatic amino acid disorder are caused due to the absence of the enzyme which is responsible for metabolism of amino acids in the body. So, what happens if these aromatic amino acids, what happens if these enzymes are absent? If these enzymes are absent, then there will be accumulation of amino acids and their byproduct in the blood and the tissues, which will cause a lot of symptoms that will affect the development of brain and central nervous system. These are the types of aromatic amino acid disorder: phenylketonuria, tyrosinemia, tryptophan disorder, and Alkaptonuria. Starting with phenylketonuria. Phenylketonuria is an inherited autosomal recessive in nature. It is caused due to the absence of the enzyme phenylalanine hydroxylase. As phenylalanine hydroxylase is absent, so phenylalanine gets diverted into a different pathway, which results in formation of phenylpyruvate, phenylactate, phenylacetate, and phenylglutamine. There are types of phenylketonuria. There's type 1, which is the classical phenylketonuria. Then there's type 2, type 3, and type 4, type 5. Here in this picture, it shows that it is the metabolism of phenylketonuria, and in this picture, it shows that a boy is suffering from hypopigmentation. Hypopigmentation is caused as there is this absence of phenylalanine, as there is this absence of enzyme phenylalanine hydroxylase. So, the conversion of phenylalanine to tyrosine is hampered, due to which the tyrosine is responsible for melanin production. So, the melanin production is also lowered, due to which the patient shows hypopigmentation like blue eyes, light hair color, light skin color. The other symptoms of phenylketonuria are seizures, mental retardation, also retarded growth development. The diagnosis for these disorders are Guthrie test, then there is tandem mass spectrometry, and there are several other tests. Now my next teammate will come forward to speak about tyrosinemia. Thank you.
Thank you, Rumi. Moving on to our next autosomal recessive metabolic disorder. We have tyrosinemia. Now, what is tyrosinemia? Tyrosinemia is a hereditary metabolic disorder in which our body fails to break down the amino acid tyrosine. Furthermore, tyrosinemia can be of three types. Furthermore, tyrosinemia can be of three types: tyrosinemia type 1, tyrosinemia type 2, and tyrosinemia type 3, characterized by the deficiency in the enzyme involved with the tyrosine metabolism. So, tyrosinemia type 1, also known as the hepatorenal tyrosinemia, is caused by the deficiency in the enzyme known as fumarate acetoacetate hydrolase. It is one of the most severe form of tyrosinemia, as it can cause liver failure, kidney failure, and even death. Tyrosinemia type 2, also known as the Richter-Hanna syndrome, is caused by the deficiency of an enzyme known as tyrosine aminotransferase. Lastly, we have got the tyrosinemia type 3, also known as the neonatal tyrosinemia. It is caused by the deficiency of an enzyme known as hydroxylase phenylpyruvate deoxygenase. Lastly, we have got the symptoms and diagnosis. In tyrosinemia type 1, the symptoms include kidney problems, liver problems, while in acute cases, the infant even shows diarrhea, vomiting, cabbage-like odor, and even rickets. In tyrosinemia type 2, the symptoms include corneal ulcers, eye lesions, and even cataract, while even showing mild intellectual disability. Lastly, we've got the diagnosis, in which we can perform the newborn screening, which is used to detect succinyl lacetone, which is used to detect tyrosinemia type 1. We can even use other clinical tests, including plasma amino acid test, urine acid test, and even genetic testing. Thank you. Now I would like to hand over the mic to Rohan.
Thank you, Samuel. Good evening, teachers and my batchmates. Now I'll be discussing you about the tryptophan metabolism disorders. What is tryptophan metabolism disorders? These are less common aromatic amino acid disorders which affect the tryptophan metabolism or tryptophan transport. Examples: Hartnup disease, where it is not a strictly enzyme deficiency disease. There is a defect in the amino acid transport in the intestine and kidneys, affecting the tryptophan absorption and leading to pellagra-like symptoms. Next comes our aromatic L-amino acid decarboxylase deficiency, which affects the synthesis of neurotransmitters like serotonin and dopamine from the precursor amino acids, including tryptophan's role in serotonin production, leading to severe neurological symptoms. Next comes xanthidinate, which is vitamin B6 in the form of pyridoxical form, which is pyridoxal phosphate. It acts as a cofactor for enzymes involved in tryptophan metabolism. When vitamin B6 is deficient, an intermediate product called 3-hydroxychitinine gets accumulated and converted into xanthidinate, which is then excreted out through the kidneys. Which is then excreted out through the urine. Next comes argentophenoma, which arises from the argentophin cells from the intestines. And last is Parkinson's disease. Metabolites like carnitinic acid can be neuroprotective, whereas other metabolites like phenylketonuria acid are neurotoxic, exacerbating Parkinson's disease symptoms. Here we can see that less tryptophan secretion leads to less serotonin secretion, leading to antisocial personality, anorexia, borderline personality, bulimia, depressive symptoms, panic, obsessive compulsive disorders. Tryptophan metabolism, less tryptophan secretion also leads to increasing kynurenine secretion, which further leads to increase in quinolinic acid and chironic acid, whereas quinolinic acid acts agonist to NMDA receptors and chironic acid acts antagonist to the NMDA receptors.
Anorexia means loss of appetite and increased appetite and increased eating. That is bulimia, just opposite. You should know it. Clinical terminology.
Sorry, sir.
Bulimia, I think you know anorexia, but not bulimia. Anorexia means loss of appetite and increased intake of food. And just opposite it is bulimia. Increase intake of food. You should increase appetite.
Sorry, sir.
You know the meaning.
Anyway, you finish. Anyway, go ahead, finish.
Now I would hand over the microphone to Rosie.
So I'll be discussing about Alkaptonuria. So this is an inborn error of metabolism of amino acids. Alkaptonuria, this is an inborn error of metabolism of amino acids, phenylalanine and tyrosine, which is caused due to the mutation of the HGD gene, which is present on the chromosome, long arm of chromosome number 3. And this gene causes synthesis of the enzyme homogenesic acid. So there is a buildup of dark pigments, which is known as ochronosis, in the skin, the connective tissue of the joints, and ear pinna, and the sclera of the eye. It is an autosomal recessive disorder, which means both the gene must be defective for this disorder to occur, and this occurs in 1 in 250,000 births. And it is mostly asymptomatic in many cases. cases. So this is the pathway. When the homogentic acid doesn't, when there is a defect in the homogentic acid oxidase enzyme, so the homogentic acid cannot convert to mallyl acetoacetic acid, then this disease is formed. Then we have the symptoms. So basically the symptoms are darkening of the ear, dark spot on the sclera of the eye, arthritis, which can get worsen over time, and we have black urine, and this disease is also known as black urine disease. So for the diagnosis, we can do urine test, and we can also do a ferric chloride test, which if it is added to the urine, it will turn the urine into black color. And for the treatment part, it is basically, for the treatment part, it is not fatal, so we don't have as such treatment, but we can refer the patient for asymptomatic treatment for management of pain and inflammation. And we can, sometimes the patient may also benefit from a high dose of vitamin C tablet, but this is not known as such. So these are the symptoms which you have seen: darkening of the sclera of the eye, darkening of the ear pinna, and turning of the urine into black color on standing. Okay. Next, I'll hand over to my colleague.
Now I'll be talking about the common manifestations and general symptoms across all the aromatic amino acid disorders. First is neurological symptoms, where we can see the person suffers from intellectual disability, delayed development, and mental seizures, along with movement disorders in dystonia and hypotonia. The patients also suffer from behavioral symptoms such as hyperactivity and irritability are too common across the patients. Physical symptoms just like fair skin color in case of phenylketonuria, and organ specific in organ specific symptoms, there are organ problems in Tyrosinemia type 1 diseases such as kidney and liver issues. Early detection and intervention are crucial to prevent or mitigate these severe symptoms. Now we come to the dietary management part, where the patients are asked to take a low protein diet and avoid harmful amino acids. Such if the patient is suffering from phenylketonuria, they should avoid phenylalanine in the diet. Next comes special medical formulas are also used for safer nutrition.
How many more slides you have?
One more.
How many more slides you have?
One more, sir. One more.
One more.
Repetitive tests are done to closely monitor the levels, and this treatment is lifelong. Next comes medications and supplements. Sapropterin dihydrochloride is also used in PKU patients. It improves phenylalanine tolerance in some individuals who are BH4 responsive. Nitisinone, which is also known as orfadin, is used in Tyrosinemia type 1 diseases, which inhibits 4-hydroxyphenylpyruvate dioxygenase, preventing formation of harmful metabolites. Vitamin supplements are used as the patients are required to take a low protein diet, so vitamin supplements are needed for normal to lead a normal life, and tyrosine supplements are also given in PKU patients. Here comes the conclusion, where we can say that aromatic amino acid disorders are rare, but they can be curable if diagnosed at the earliest time with lifelong treatment and care. Thank you, sir.
How about you? Okay. Thank you. Well, this is another example how a slide should not be made. Okay. Your preparation is not good, number one.
a very important topic.
Number 2, what you have written, you have no idea. Number 3, you have not gone through what you have written and you have not counter-checked. There are many misinformation, wrong information. And
Which one is correct? One basic question I am asking. We have 2 amino acids complexes. One is phenylalanine and it is tyrosine. Can you tell me which one is essential? Both are essential. Which one amino acid is essential? Tell me.
which amino acid is essential, phenylalanine or tyrosine? Which one? Michael, what?
So tyrosine is semi-essential.
Tyrosine is semi-essential. And phenylalanine?
That's all.
Essential. Sure.
As far as I know.
Phenylalanine is essential, correct. But tyrosine is not semi-essential. Hey, quiet! ইয়া কি হচ্ছে নাকি এটা?
কখন থেকে তো গড়বড় করে যাচ্ছে একটা কোশ্চেন তো অ্যানসার করতে হবে না পাস করালে তো পাস করবে না তাই তো এবার ক্লাসে বসে যে একটু ভর্তি করে সেটুকু মানে বাবা মা শেখায়নি কি করে ভর্তি করে রাখতে হয় কি করে রাখতে হবে এইটুকু ভর্তি করে যে একটা সেমিনার বলছে তোমার কলিগস তুমি শুনতে না মজা করছো মোবাইল কি করছো সার্চ করছো
Tyrosine is not semi-essential. Histidine and arginine are semi-essential. Okay? So, fine. So, actually, this is a very large, vast topic. So, you should have gone through, like, in 1 or 2 slides, you should just maintain the flowchart of the metabolism of each individual amino acid. Then you should have gone to the individual amino acid disorders, names, enzyme defect, followed by their cardinal features, the main features. That's all. That's all you can say in a time of 15 minutes, span of time of 15 minutes. You cannot cover the whole thing. You just cannot take up from the book and print.
One is the name of the disorder. Second column the deficiency of particular enzyme. Third column is the cardinal features.
That's all.
Yes. And last of all, you may mention the treatment. Treatment is the more or less same in all cases. Because the low protein diet. Can you mention which amino acid should be low and which amino acid should be high in case of phenylketonuria, treatment of phenylketonuria? Which amino acids should be low quantity and which amino acids should be high quantity? Bolo. Regarding dietary management of phenylketonuria. Which one? Tell me. Which amino acid should be low in diet and which amino acid should be enriched in diet and why?
Phenylalanine should be
Phenylalanine should be low
less in that.
and tyrosine will be high.
Tyrosine supplements are given, that's what the questions.
So you don't know.
So,
Why inborn errors of amino acid metabolism is important? For early diagnosis is very, very necessary. Why? Early diagnosis of the phenylketonuria is very, very necessary. Why?
so
If it is late diagnosis and late treatment, what will happen?
So mental retardation.
Mental retardation. We are concerned with mental retardation. All of the features can be reversed by dietary management, except one, that is mental retardation. You cannot reverse. Once mental retardation develops, you cannot reverse it by any means. So, early diagnosis is essential in most cases of the inborn errors of metabolism. May it be protein metabolism, amino acid metabolism, may it be carbohydrate metabolism, may it be fat metabolism. Whatever may be the metabolism, the inborn errors should be screened very, very early stage and should be treated from the very beginning.